So I'd like to kick things off with our first presenter, and it's Dr. Alan Abdulla, who will be presenting on the DOLPHIN randomized controlled trial and lessons learned on it. It's a very important study for us. It's probably the first ever study that was done in this setting. And Dr. Alan Abdulla is a postdoctoral researcher and hospital pharmacist at the Department of Hospital Pharmacy at the Erasmus Medical Center in Rotterdam, in the Netherlands. His research focuses on pharmacometrics, therapeutic drug monitoring, model-informed precision dosing, and sustainable sampling strategies in specific patient populations, with a particular emphasis on children and critically ill patients. Dr. Abdulla has conducted two key trials, namely the XPAT, and of course the one he'll be speaking about today, which is the DOLPHIN study.
Sure, thank you very much for the kind introduction. I will start the presentation. Again, thank you very much. I would like to present some key results from the DOLPHIN trial and some lessons learned in the coming few minutes. So first of all, we all know that critically ill patients are a highly heterogeneous population with significant differences in the distribution of age, disease severity, length of stay, and also clinical outcomes. So treatment in this population is therefore one of the most complex and also expensive within the healthcare setting. And infections in critically ill patients are a major source of morbidity and mortality in the intensive care units. So I will start with some backgrounds why we started this trial. So we all know that critically ill patients have altered pharmacokinetics. This is well established in the literature. This could lead to suboptimal concentration or exposure, and eventually may lead to risk of therapeutic failure or even worse, resistance. So some major key aspects are that these patients have hyperdynamic status, of course, so increased cardiac output and therefore changes in the clearance and also plasma concentrations. There are a lot of other factors such as altered fluid balance and organ dysfunctions and also extracorporeal circuits, which will eventually affect this altered pharmacokinetics in these patients. We know from the XPAT trial that the exposure of beta-lactam antibiotics could be somehow less than you want to. So the blue areas here are presented are below the target, the green area on target, and the red area above the threshold of 10 times MIC. To summarize this, we know that about 40 to 60% of the patients have adequate exposure getting beta-lactam antibiotics in the ICU setting. And for ciprofloxacin, it's even worse, 15 to 30% of the population. So how can we optimize the antibiotic dosing? So focusing on the beta-lactams, we know, like I said, that about 40% of the patients are off targets. So that's the reason why we want to do dose optimization. And the way to do this is to use, for example, interventions like TDM. And what you can do is look at trough concentrations to know if these patients are on targets and have exposure beyond the MIC. So therefore, we want to study this population in a large RCT. So we conducted the DOLPHIN trial, which is a trial where we look at therapeutic drug monitoring combined with model-informed precision dosing of beta-lactam antibiotics and fluoroquinolones. And we want to not only look at target attainment, but we want to look at clinical outcomes to see if this intervention will lead to better outcome in this population. So I will discuss the study flow of the DOLPHIN trial, because I think it's important to know that it's a difficult trial to set up, but also a difficult intervention. TDM might sound like it's easy to implement, but in this population, it's pretty complex. So we start with a patient which gets antibiotics, and then this patient is included, and two samples are drawn, a trough level and a peak level. We needed two levels to calculate the exact exposure and the time above MIC, or the AUC for the ciprofloxacin. So the analysis were done, and this analysis were used in Insight RX to model and the results were discussed with physicians at the different ICU settings. Combined with patient status, the most optimal dose was used to have the individualized dosing for the specific patient. And we did this on day 1 after randomization, day 3, day 5, and again on day 7 we measured the trough levels, but we didn't do any intervention. It was just to check if the intervention on day 5 was adequate. So what we did for the DOLPHIN trial, we used pharmacokinetic models that were published in peer-reviewed studies. And after a literature search, the PK models, which were used in ICU patients, were selected for Bayesian estimations. These models were selected by experts and tested so that we had the most adequate models. So the models who performed best were the top performing model were used for model-informed precision dosing using InsightRx, which is an online tool to model and use MIPD. So the DOLPHIN trial was conducted between October 2018 and September 2021. And in total, 8 ICU departments across the Netherlands were included. And we included 9 different beta-lactam antibiotics and also ciprofloxacin. So now I will discuss some major outcomes of the DOLPHIN trial. The trial is published in 2022. So in total for this trial, 484 patients were randomized, and for the main cohorts, we analyzed 388 patients. So these are some key patient characteristics. So overall, 62% of the patients were male, and the median age was 64, with a median Apache 4 score of 70. Most patients had sepsis without shock, and in 24% of the patients had also septic shocks. And the median SOFA score was 8. So looking at a trial, patients which were included on T0, so at randomization, we only included these patients for the intention to treat analysis if there was also a sample at T1, so the first sampling moment. So that will lead at 100% of the population at T1. But after the trial continues, some patients, of course, were discharged or were stopped using the antibiotics. So the total amount of patients left at T5 was 28% of the total included population. Of these patients, 53% of the patients had a positive isolate, and the most of these patients had pulmonary infections or abdominal infections. So looking at the primary outcomes, we saw that the length of stay was not different between the two groups. So the MIPD and the standard of care, the length of stay was not significantly different. We also looked at secondary clinical outcomes, so length of stay after the randomization, so after T0, and also ICU-free days, ICU mortality, and also the 20-day mortality. All these primary and secondary clinical outcomes, we didn't saw any significant difference between the populations. So I want to zoom in a little bit more on the variation and definitions of the ICU length of stay, because I think it's a very important measurement in our study, but still there is a lot of discussion how to interpret this data and what is the best ICU length of stay definition. So we can see here some different scenarios how to calculate the ICU length of stay. So from admission on, you can register the time where the patients, of course, are admitted. Then you have the randomization moment, the intervention, so the actually conducted model-informed precision dosing moment. Patients could be ready for discharge, but most often we use the actual discharge moment. And in the DOLPHIN trial, we used the second scenario, where we had the T0 at randomization, of course, and the different time points where the MIPD was conducted. So comparing the two groups, we saw no significant difference between the ICU admission duration prior to randomization, although the range of the MIPD was a bit larger. Again, the ICU length of stay wasn't significant difference between the two groups, but we also looked at the ICU length of stay using scenario 4. And again, also here, we didn't see any significant difference. I think ideally, when you look at these kind of interventions, you should look at scenario 5, where you look at the ICU length of stay from the moment of the intervention until the patients are ready for discharge. However, ready for discharge is pretty difficult to register in these kind of trials because this date is not often very good registered in the patient's healthcare records. So looking at the study flow again, we see here the ICU patient population in the total population, where we see that at T0, about 60% of the patients were on target or had the advice to be on the same dosing regimens. And eventually more patients were or on target or had to be on the same dosing level. So, however, the target attainment in the total population was about 64% for the beta-lactam antibiotics and 40% for ciprofloxacin, which is in the range of the literature we already know. Looking at the model-informed precision dosing population, you can see here different time points where the target attainment was measured. However, if we zoom in, we see that in a significant proportion of patients, no dose adjustment were eventually conducted in the patients which were not on target, so the non-target attainment population. The main reason, however, was that in this population, some of the patients were already on a maximum daily dose defined prior in the study, and which was based on local dosing guidelines and also product summary specification for these drugs. So this means that some of the patients which were not on target should stay on the maximum dosing. So we didn't saw any significant difference in clinical outcomes. However, I think that the future for MIPD is still bright, and I want to give a little glimpse in some future research in this population and some things we are already conducting with the data from the DOLPHIN trial. So we did some interesting post hoc analysis where we looked at which patients could actually benefit from model-informed precision dosing. In this graph, you can see a few interesting patient population or subpopulations where we saw that patients which had a SOFA score less than 8 had better mortality outcomes, and also patients which were would had an intervention within 24 hours prior to randomization had a better delta SOFA score, so a better improvements in organ function. So in general, we saw in the population that the patients which have most benefit from TDM should be patients with a lower SOFA score, and also patients where the intervention is conducted in the early phases of the infection or the early phase of the treatment started. However, we also wanted to know which patients are actually at risk. So we know that 40% of the patients have lower exposure, but there are some specific patient characteristics which will eventually be the patients who will benefit most of the treatment or the model-informed precision dosing strategy. From literature, we already conducted a review where we saw that there are some significant predictors for target non-attainment and also for target attainment. However, using these predictors at the moment of initiation of treatment is pretty difficult. You have to consider all the different factors. So it's not easy to only know this from the literature. We should also translate this to easy to implement and easy to use tools for the clinicians. So what we did is we conducted some machine learning algorithms. One of them was random forest, where we look at all the data we had from the DOLPHIN trial and the expert trial. And basically in these analysis, you use a lot of decision trees where you use the data and try to come up with an algorithm where all these different decision trees leads to a specific algorithm and have an average vote for the best outcome. So we used almost 600 data points from the patients from the expert trial and the DOLPHIN trial. And we conducted about 1,000 decision trees, and these predictions were used to average all the predictions, and this was translated to a random forest model. And this model was eventually translated to an easy to use online tool where we can use the models we made to predict which patients are off target, and only using variables available at the starting point of the treatment. So in this case, age, serum creatinine, sex, and also the antibiotic. And this tool will provide the chance of target non-attainment and also advice to consider TDM or model-informed precision dosing. So to conclude, should we TDM or not? I think TDM in this population is very feasible if you know in which patients you should use the TDM for. So we know that not all patients are on target. So you should focus on the patients which are at risk for target non-attainment. It's important to, if you want to inform your decision-making on TDM, to draw the levels within the first 24 hours of the treatment. Using the models and the model-informed precision dosing tools, you can then adjust, of course, the dosing, but you should also, in this case, in critical ill patients, avoid the limitations of the SMPC dosing targets. So with that, I would conclude this presentation. I'm open for any questions.
Thanks very much for that, Alan. That was an excellent presentation on a study that we've been, in our group, looking at quite specifically on what we can learn from it, and your presentation just added to that, especially the machine learning component. I think we'll save questions for the end, because we do have about 15-20 minutes of question and answers for all of the presenters. So we will leave some of the questions. I've got a few, but obviously there'll be some from the audience as well.